There we go. Yep, we can see his screen now.
It advances now. Is it going to advance? So you cannot be able to do both at once.
Yeah.
Hold on. Oh gosh, this is really painful.
If you tab over with the arrows, there you go. Okay.
There we go. Can't get my mouse. Oh, there's the mouse. Hold on. Oh, I see. It's going to the right. Okay, there's the mouse.
Thank you.
But you want to go back, right?
Yeah, I want to go back.
Okay, where are the arrows?
My
Okay, there you go.
Oops.
No,
okay. So patients at risk of toxicity have or have unclear symptoms can be assessed by fundus autofluorescence and multifocal ERG. And toxicity shows a paracentral ring of hyper or hypoautofluorescence. But once you see the paracentral ring, that typically is an indication that retinopathy has progressed. Or our goal is actually to prevent seeing the paracentral ring. Okay, if I can advance this. Oops. Advancing. Yeah, so this was about hydroxychloroquine, and now we'll talk a little bit about phenothiazines. They are prescribed for psychotic disorders, and they include chloropromazine and chlorhexidine, and they are concentrated in uveal tissue and retinal pigment epithelium because they bind to melanin. And high dose chloropromazine causes abnormal pigmentation of ocular adnexa. Pigmentary retinopathy is unusual, and again, those are very rare conditions. But if one encounters a patient on a high dose, like more than 800 milligram per kilogram for chlorhexidine, it can cause severe pigmentary retinopathy, which can be divided into 3 stages: early stage, mid stage, late stage. And but in late stage, it is chorioideremia with or bietic crystalline dystrophy. So it is quite remarkable, and you can see on the fundus pictures. And I guess this is fluorescein geography, widespread degeneration. And symptomatic patients at the high dose should undergo a full retinal evaluation. Okay, so let's try to advance again. Okay, thank you. Sure. So now we're talking about the next group according to the book, and this includes clofazimine for leprosy and psoriasis. It can cause also bullseye maculopathy. The ferroxamine for iron chelating agent. It can cause vitiliform RPE changes. Then we are talking about some anti-AIDS drugs like dideoxyinozine, which can cause optic nerve and RPE changes because it causes mitochondrial toxicity. And then there are MEK inhibitors, corticosteroids also. Corticosteroids are very common, but they do not cause generally that much damage outside of swelling, or sometimes, they reduce swelling. But alkyl nitrates or poppers in rare cases can cause toxic maculopathy. Okay. Then drugs causing occlusive retinopathy or microvasculopathy. Those include interferon alpha 2A, ergot alkaloids, and oral contraceptives. They can lead to vascular occlusions, BRVO, CRVO, and procainamide for arrhythmias can cause retinal vessel changes. Also, aminoglycosid, amikacin, and gentamicin, if administered intraocularly, can cause macular infarction and severe macular ischemia. This is again very rare. Intracameral vancomycin for prophylaxis of endophthalmitis. That's again, as far as I know, rare. Can cause hemorrhagic occlusive retinal vasculitis. So those are the drugs that cause occlusive retinopathy and microvasculopathy.
Do you guys use antibiotics after surgery at all for cataracts?
He does,
Everyone does something a little differently. Some of the attendings after VA will actually inject moxifloxacin into the eye, and they say that they have very low endophthalmitis rates. We were just talking about yesterday how some of the attendings at USF will use moxifloxacin 3 days before to clear the ocular surface. We tried to look up if there was any evidence to use that, and then the AAO, they had a kind of a weird position paper that was very vague. They said you can use it the same day of, and it clears the ocular surface rapidly within hours, like moxifloxacin, and then of course use the betadine during surgery. But they also didn't cite any studies as usual.
But nobody injects antibiotics anymore.
Some of the attendings at the VA still do.
Moxie.
Moxie, yeah.
Oh, but not like gentamicin or Vacco or stuff.
We only had one case where we thought about, just for regular surgery. No.
Yeah, okay.
Okay. So now we can move to drugs causing ganglion cell and optic nerve toxicity. And number one is quinine, which is used as a muscle relaxant for leg cramps and as an antimalarial. Again, rarely, which is safe at less than 2 grams, but at some lower doses it can cause toxicity, like RGC toxicity mimicking central retinal artery occlusion, and cherry spot may be observed, and we can see GCL thickening and hyperreflectivity on SDOCT. And of course, once it progresses to end stage, it can be diffuse retinal atrophy and etc. And blindness is permanent. Methanol, of course, is a very dangerous stuff. People who do moonshine and stuff like that, and they can be, they can ingest methanol and then get optic nerve toxicity, transient optic nerve head and macular edema. The retina, RP, and optic nerve demonstrate vacuolization and eventually optic atrophy and occasionally retinovascular attenuation caused by diffuse RGC loss may develop. Okay. And yeah, full field DRG testing shows a negative waveform. But again, even that is rare.
Yeah, it looks like
Oh,
we've been trying to help out here.
So now we come to the drugs that maybe a little bit less dangerous, but still they can cause problems, like macular edema, and the taxanes are a class of microtubule inhibitors used in oncology that include paclitaxel, albumin-bound paclitaxel, and doxatel, and they could be associated with macular edema. And so, similarly, nicotinic acid can produce macular edema. Glitazones, fingolimod for MS, used for MS, and topical prostaglandin F2 alpha analogs can cause macular edema, but those are small case series. Also, the ferroxamine can cause macular edema by RP toxicity. Okay, and we're approaching the end of this. So we're talking drugs that cause crystalline retinopathy. These those are tamoxifen, cataxanthine, and talc emboli, and all these stuff can cause crystalline retinopathy. It's not very visible here, but I think in a fundus exam you cannot mistake it. The crystals in they're very, very well defined.
The one thing, the tamoxifen can look a lot like macular telangiectasia, which is interesting.
Significant visual loss in severe cases, but it may be reversible. And in rare cases, show central loss of inner segment ellipsoid. So I don't think we need to. Ethylene glycol, again, very rare. But I don't think we need to do too much about that. And of course, there is West African crystalline macropathy, which is extremely rare. Okay. And now the last group of drugs is drugs that cause abnormalities in color vision and ERG. Again, less dangerous than the other ones, but one has to be aware of that. And those include sildenafil and tadalafil. Oops. They inhibit PDE6, and that can cause color vision changes. This is temporary and reversible, typically, unless there is very high dose. And also, digitalis can cause tinting of the vision, xanthopsia. The more important one is probably isotrenion, because isotrenion is still used by dermatology for treating some dermatological conditions, and it can cause nyctalopia. And also, the gabapentin can be very dangerous and very toxic, but this is the reason why there was a special program, so nobody can prescribe easily with gabapentin. They have to go through this Bril REMS program, and where the kids that are dosed with gabapentin are tested every 4 weeks, and even after stopping treatment, they are tested about possible toxicity.
Do you recommend your dystrophy patients specifically not take anything, or do you think it's for patients with retinal dystrophies like retinitis pigmentosa? Do you tell them to avoid anything special, or not really?
No,
Okay.
no. Yeah, that's
Yeah, it's like a weird. I've heard people say.
it's complicated, but generally speaking, no. So, and this is the last category, miscellaneous drugs causing ocular retinal toxicity, rifabutin, which is treatment of AIDS, and acetylzolomide and topiramide can cause myopia and retinal choroidal folds, macular edema. Those are all transient things. Rare reports for bupropion, which is for depression. And this was curious, I was not aware of that silver, some people take silver, which can cause, of course, ocular argyrosis, and may develop after ingestion for more than 1 year, which can cause to pigmentation, dark choroid, and all kinds of other changes. Okay, so now we'll come to the more important topic about hydroxychloroquine and chloroquine. So chloroquine sulfate and chloroquine phosphate are used mostly in Europe. In the United States, we use hydroxychloroquine sulfate or Plaquenil. And just note the number, 460,000 prescriptions in March 2019, which equates approximately 5 million each year in the United States. So that's why this problem is so serious. This is just prescribing. This was before the pandemic. We're not talking about prescription related to the pandemic. But the key thing to know why this is a problem is there is slow elimination half-life in plasma, both for chloroquine, which is 6 to 14 days, and hydroxychloroquine is more than a month. And in blood is even close to 2 months. Retinal half-life is unknown, and it is presumed that it's longer than in plasma. So it's really, really slowly clearing up from the retina. First, retinopathy was reported in 1959. And their most early definitions of retinopathy were based on morphologic changes. But more recently, 20 years ago, they switched to more of a functional changes, and that's what Easterbrook said. He's from Canada. Anti-malarial maculopathy is defined as bilateral, reproducible, permanent visual field abnormalities confirmed by two different tests of the visual field. That definition came before the widespread use of multifocal ERG. Now, perhaps this can be modified, but still, most physicians use this definition, and visual field is still the officially recommended screening tool. Okay, so what are the therapeutic indications?
Could you speak about weight-based dosing and like ideal body weight versus actual body weight?
Yeah, we'll
dosing?
come to that in just a moment.
Okay.
Right. You see that it is why the numbers are so big, because there are different categories of physicians that prescribe it. Rheumatology loves it because it's effective, and in rheumatoid arthritis, Sjogren's, and other disorders. Dermatologists love it. Even it's used in some oncology and in pediatrics. So there is widespread use. Let's see.
Do you want to go forward?
Okay. So, what is the incidence of retinopathy? Well, the incidence of chloroquine retinopathy has been established a long time ago and hasn't changed. And it's about 6 to 7% of all cases. But the incidence of hydroxychloroquine retinopathy is controversial to this day. And the largest study that I'm aware of came in 2010 by people at Stanford, Mike Farmer and others. And they reported 1.8% overall across the board of close to 4,000 patients. But in the general population, it is considered below 1% and possibly underreported with lack of good epidemiological studies. Of course, it is duration of treatment related. So the longer the treatment goes on, the higher the percentage, the higher the rate. And of course, it not only exceeds 1% after 5 years of usage, but then it increases almost linearly after that. And now we come to what that will be on the next slide, but just to mention, for patients strictly adhering to those less than 6.5 milligram per kilogram lean body weight during the first 5 years, the incidence is assumed to be very low, 1 in 1,000. But if we take 5 million patients, that is still 5,000 people who will develop toxicity. So it is a problem. Okay. So is there a progression? So that is probably the most important question that the patients ask. What will happen if I stop it? Would it progress? And there are not very many good studies because there is no, most studies that have been done on these subjects, they are cross-sectional. They are not longitudinal. And that's why we don't have good information. The best study is again from Easterbrook. And he claimed that progression in patients with minimal scotoma, asymptomatic and normal color vision, the retinopathy does not progress after cessation of the drug. In contrast, in patients with abnormal color vision and positive fundus changes, in 2/3 of them, the retinopathy progresses even after the drug is discontinued. Okay. And now, oops.
Dr. Tzekov, are
Yeah.
those fundus changes, like if you were doing a clinical DFE, or is that fundus changes on imaging, like small changes on imaging for the fundus?
Yeah, okay. So fundus changes, once you get to bullseye maculopathy, it's too late. Autofluorescence is more sensitive. We'll come to the table. I'll show you the table in a moment, but functional changes precede morphological changes, always in CQ8, CQ maculopathy. So you have multifocal ERG, visual field, and then fundus changes develop. And it depends from patient to patient. Some fundus changes progress much faster, some fundus changes progress slower. It's hard to predict. That's why the goal is to prevent
Mhm.
fundus changes from occurring. Okay, so visual field, as mentioned, was considered the gold standard. Because it's more sensitive than other methods. We will see that this change in a moment. However, assessment may be difficult because some patients may have visual field defects without pigmentary lesions. Others do show macular changes not associated with visual field defects. That can be reported too. And some patients just do not show defects with white stimulus, and that's why people introduced in the late 80s, they introduced the red stimulus, which showed great sensitivity, but not very high specificity, and this is a problem. Color vision testing is variable and it's difficult to quantify. It's possible, but the range is quite wide, and fundus changes appear too late. Okay, oops, sorry. So full field ERG is not useful. I won't go into too much detail. There is no point because everything is concentrated in the macula. Macula is a very small part of the retina, only 5%. Full field ERG won't show much. Okay. And yeah, this is full field ERG, again, showing great variability. I did this study at Stanford with Mike Monward. And you see toxicity in scotopic copy amplitude or in cone, in maximal or scotopic. It's not different from the other categories. So there is not much use for full field ERG. Okay, and that's why people use multifocal ERG. Because multifocal ERG tests only the macula. Stimulus is typically a hexagonal pattern. Here is shown 103 elements. We use 61 elements, but doesn't matter. And then Welch transform is applied. And then we get this topographical map of the retinal function, macular function, which is very useful. This is Eric Sutter who developed it in the late 80s. Okay. Now, there have been many reports of HC2 toxicity with multifocal ERG. We cannot possibly mention everybody. But the first report came in 1999. So you see how the first report came after it was well established that visual field is sensitive, and that's why the visual field definition is still there as the gold standard. But in 2017, this paper was published by British physicians who cited somebody else who did a study evaluating the sensitivity and specificity of tests about testing CQH, CQ toxicity. And as you can see, multifocal ERG has the highest sensitivity and the highest specificity of all the tests. Combination of tests is also possible, but surprisingly, if you combine multifocal ERG with visual field 10-2, yes, the sensitivity increases a little bit, but the specificity goes down. So one has to be careful. Okay. This is again a study that I had a chance to do many years ago. This is just to show you with a 6 ring, so multifocal ERG, the results get, and I already talked about this when we had the ERG lecture some time ago. that the stimulus, the results are usually averaged across rings. And when you have 103 hexagons, we have 6 rings. So here is ring 1, ring 2, ring 2, and ring 6. Ring 2 is the parafoveal area. And one can see, so this is the normal range. You can see the dip. So that goes below the normal in people with toxicity. Those were just, this was just one case where we have 3 data. And you see in the other categories, this pattern is not very prominent, although this may turn out eventually to become toxicity. You see there is some similar pattern of changes.
Dr. Tzekov,
Yes.
for the previous study from 2017, I'm not sure if I'll word this properly, but what was the gold standard against which they compared the sensitivity and specificity? Because they tested so many.
I'm not aware. I don't think they used one gold standard. I think they did some combination. I haven't read it in detail, so I don't want to mislead. But my understanding is that they didn't use one gold standard. I'll come back and I'll update you on that once I read carefully the whole. Okay. Yeah, so this is just to show you that even with multifocal ERG, the standard stimulus may not show anything. So this is the top two panels. This is just standard ERG, multifocal ERG, and there is no change. These 2 panels, which are below the top 2 panels, they show some change because a different stimulus was applied. So we can change the stimulus. So this is the original testing, and then 8 months follow-up testing. Again, no changes with the normal stimulus, but with the alternative stimulus, we see slightly different pattern of changes. So maculopathy can be subclinical. It typically starts subclinical, and it can progress, and progression is individual. It's very difficult to predict. Okay, so people have recommended using ring ratios. That's what we use right now. But this is still a project under development because we have to find out how the ring ratios correspond with other stuff. It's complicated. Okay. So this is an important slide. There is an example. The example that shows multifocal ERG, you see the depression. This is the central element. Around it, the signal is depressed. And that corresponds fairly well with the visual field. Whereas you don't see much changes in the OCT, and there are not much changes in the fundus photography. And here there are not very many changes either. And also this table is important. That's what they did in this very big study at Stanford, which was also not just Stanford, but a very big practice in Northern
I think
California.
it was Kaiser.
Yeah, right.
Oh, it's okay.
And
That's all.
they summarized everything. Yeah, Kaiser, right. And they summarized everything, and what they found was that in Asian patients, there is a different pattern of macular toxicity in the sense that it spreads much more in the pericentral area compared to white, Hispanic, and blacks. And this pattern is very visible here. So we have 5 Asians versus 16 parafoveal versus pericentral, whereas in white people there's 101 versus 2. And that's why the American Academy now divides. Yeah, well, I think. See. No. the American Academy, in their recommendations, that divide the algorithm in two ways. So we have Asian patient or non-Asian patient. You use different visual field, because in Asian patients it's better to use 24-2 or 30-2. And also wide field OCT, whereas in white patients we can use 10-2 and normal OCT. Okay, so this is a example of progressive stages of retinopathy. Top one is normal OCT, normal visual field, mild retinal toxicity, a little bit of change, not very much happening in the OCT. And with moderate toxicity, one can see what's described as the flying saucer at the very center. And of course, there is a ring scotoma. And once it progresses even further, then it can become very bad. The retina is basically collapsed. And there is a very dense central scotoma, so it can be devastating. I actually encountered a patient here at USF who was with severe toxicity. That was about 10 years ago. It was really sad. Anyway, so I think we don't have much time, so we have to wrap up. But the key point is, unfortunately, whatever recommendations are, you have to be very cautious with CQ-HCQ, and an individual approach is recommended. And this quote is from 2000, but it's still somewhat valid today. And it says, any patients taking HCQ in any amount and for any length of time who complains of disturbance of central vision and who has persistent alteration of arm therapy, now nowadays they don't do arm therapy anymore, or visual field in the central areas, or worsening of color vision testing should be considered to have toxicity until proven otherwise. So better to be on the cautious side than to end up with something devastating.
And how often are patients actually symptomatic from this?
I'm sorry?
How often are patients actually symptomatic from this? Because I imagine it's so slowly progressive.
It's complicated. They describe it in different ways. Most people say blurriness, blurriness is non-specific. Okay. Because the initial changes are so subtle, that what patient tells you, it's rarely informative. Testing is needed.
Yeah.
To confirm. And that's why those big problems were established. That's why the American Academy, they issued the first recommendation in 2002, and the second recommendation was in 2011. They corrected it in 2016, so right now it's still the 2016 recommendation, which is valid.
What's the current recommendation as far as screening? Is it well defined, like as a practice pattern?
Yes, I mean, it is defined, but I mentioned that I think you should be aware that individual approach is preferred. Of course, the typical recommendation is that the first 5 years, you don't need to test them. You test them once, you do a fundus exam, and you wait for 5 years. But anybody who complains of any central vision changes should be suspected. And I think that is the better approach.
So the first time it can be just a fundus exam, or do you guys do like an OCT and a visual field the first time when they start?
At USF, we do typically the patients who start on plaquenil, and that changed, by the way. It changed about 2-3 years ago. We kind of adopted slightly different policy. And now when the patient comes, if they're asymptomatic, if everything looks good, they go on the drug. But any patient who the retina specialist, and of course, there is always full fundus exam at the beginning. If the patient shows some other changes, like signs of AMT or anything else, and of course, if there is concomitant drug use like tamoxifen or something like that, then they do visual field, OCT, and multifocal ERG. Multifocal ERG is good to do at the beginning, so to have a baseline. And then any change later will be compared to the baseline. That's what we do right now.
I think between our 3 retina docs, they all do it a little differently. And I remember one time we sat down and looked at the guidelines that they gave. It was kind of just like recommend 2 out of the 3 modalities. And then someone said, oh, you don't have to do visual fields anymore. You can just, I don't know. It was,
Look, I'm somebody who has done objective visual field testing. I'm objective vision function testing for a long time, so I'm comfortable with the space of objective vision function testing. But some people may be intimidated by that. But that's what we do here. Yeah, just to mention, at USF we have the advantage that our multifocal ERG tests both eyes simultaneously. Some of the older system, you have to test one eye and then switch to the other eye, which makes everything longer. And sometimes there are what's called an order effect. So it depends which eye do you test first and stuff like that. So here we're in a better shape. Okay.
I have a question.
Yes.
So do you recommend, so I won't typically order a multifocal ERG unless I suspect there may be some toxicity, like if there's some change on a visual